So our GI quiz this week covers chapters 50, 51, 52, 53, and then also I want you to review chapter 55, which is just information about nutritional supplementation. Specifically, just look through back through the information about enteral and parenteral feeding, so feeding tubes, and then things like TPN and PPN, just to refresh your memory on those. Chapter 50 at the beginning does, on 816, page 816, does a really awesome job of talking about the pathophysiology of acid-related conditions. So we're going to start with acid-controlling drugs in chapter 50. Basically, the stomach secretes a bunch of different enzymes and acids. So hydrochloric acid that helps with digestion. And also, one of the reasons why we want the stomach to be so acidic is so that anything that you eat, if it has any bacteria or fungi or viruses or parasites, the acidic environment ideally would kill most of those things. So most bacteria, if you remember from microbiology, don't live in extreme acidic environments. So the hydrochloric acid is essential in playing a role for pathogen prevention. Bicarbonate then is used as a base to buffer to maintain an optimal pH level. So obviously there's going to be less bicarbonate than hydrochloric acid. Pepsinogen is an enzyme. It's the precursor to pepsin, and it helps digest dietary proteins. Intrinsic factor we talked about, that is a glycoprotein, and it helps with the gastric absorption of B12. And when it's lacking, we have pernicious anemia. And then there's mucus. As I said, like the goblet cells secrete mucus, and that protects the stomach lining from the hydrochloric acid and the digestive enzymes so that we don't have erosion. And then we have prostaglandins, and they have anti-inflammatory and protective functions within the wall of the GI tract. You can see here they show like pyloric glands, fundal or gastric glands, and then the different types of cells. So there's chief cells, parietal cells, mucous cells, epithelial cells, and different parts or zones of the stomach, because they have slightly different roles, have slightly different cells. But probably one of the ones that we're most worried about or most concerned about are the parietal cells, found mostly in the gastric zone. And if you remember today in the lecture, they were showing like a lot of the gastric ulcers occurring in this area right here. So the parietal cells produce and secrete the hydrochloric acid. The chief cells, which are also in this zone, in the fundic or gastric zone, secrete the pepsinogen, which is the enzymes. And then mucous cells are found pretty much all over this entire area here to protect and coat the lining of the stomach. Okay, the cells in the gastric gland then, which we just looked at, are the largest in number and of primary importance when discussing acid control. So we're thinking really about that center section of the stomach when we're talking about all of these secretions. We just went over those. So the parietal cells, as I said, produce and secrete hydrochloric acid. And so when we're talking about our blockers, we're talking a lot about like our H2 blockers, our anticholinergic agents, and then our proton pump inhibitors all work on these parietal cells. So this is a picture of a parietal cell, and basically they have these little lock and key mechanisms across the surface of the cell. And they have acetylcholine, histamine, and gastrin receptors. At any point in time when something locks into one of these receptor sites, it allows the cell to produce and secrete the hydrochloric acid. Okay, so You can read more about this on 816 and 817. It's actually pretty interesting, but you don't need to know that, for the exam necessarily. And then down here is where the proton pump inhibitors work, and they work in this area here. So they actually stop the secretion of hydrochloric acid. So anticholinergic agents, to a degree, will inhibit the total activation of the parietal cell. H2 blockers, same thing, will inhibit the total activation of the parietal cell. If you had a gastrin blocker, it would do the same thing. But the proton pump inhibitors are the only thing that actually totally prevent a release of hydrochloric acid. So that's why the proton pump inhibitors tend to be the heavier hitters or the more effective medications, but you need to use them long term because it takes a while for them to be to build up and become effective, and to for the acid that's already in the stomach to wear itself down. The chief cells then secrete the pepsinogen, which is the proenzyme or the precursor to pepsin. And so pepsinogen then binds to or interacts with the hydrochloric acid and becomes pepsin, and that breaks down proteins within the stomach. So it's what we consider a proteolytic, or something that can break down a protein. Mucus cells, as I said, coat the stomach lining with mucus to protect it. And hydrochloric acid, this is interesting. So it's secreted by the parietal cells when stimulated by things like food, caffeine. So caffeine definitely has a huge link to stomach ulcers, chocolate, and there's caffeine in chocolate as well, but chocolate itself, and then alcohol. So in addition to just regular food, caffeine, chocolate, and alcohol. So when we're doing teaching with people and they have gastric ulcers, not only do we want to tell them to avoid like acidic and sometimes spicy foods if that bothers them, but they need to, for the 6 weeks that they're on therapy of their proton pump inhibitors, avoid things like caffeine, chocolate, and alcohol. Okay, the pH of your stomach is roughly the same as well, it is hydrochloric acid. It's a definitely an acid. It's incredibly acidic, 1 to 4, which is why you need all that mucus and the prostaglandins in there protecting the lining of the stomach. Okay, and again, it helps with digestion for it to be so acidic, and then it defends against microbial infections. So that's huge, because if you're on proton pump inhibitors long time, now you've also increased your risk of GI infections. Okay. And then large fatty meals and emotional stress also increase the amount of hydrochloric acid in your body. So we have peptic ulcer disease, and we have the Helicobacter or the H. pylori infection. So 90% of adult patients who have duodenal ulcers and 70% of adult patients that have gastric ulcers test positive for Helicobacter pylori. And so what we do is a proton pump inhibitor and 10 to 14 days of usually dual antibiotics. So they're usually on at least 3 medications for 10 to 14 days. Okay. And then we have the stress-related ulcers, which I was talking about, and these are common in ICU patients, and these are related to things like ventilators, NG tubes, so they should always be on PPIs, right? So we always start people on PPIs. We also might give them an H2 blocker like Zantac through their IV to decrease the histamine and the overall release of hydrochloric acid in the stomach, but we usually start them long-term kind of prophylaxis on the PPIs. So there's 3 types of drugs mainly that we use to control acid. There are antacids, H2 antagonists, and proton pump inhibitors. Antacids basically usually are made up of salts, so aluminum, magnesium, calcium, or sodium, and then sometimes they also include simethicone, which is our anti-gas drug or our anti-flatulent. They are indicated for the use or relief of heartburn associated with peptic ulcer, gastric hyperacidity, gastritis, and then just, run-of-the-mill heartburn. They don't prevent overproduction of acid, but they neutralize acid secretions. Right. And they help promote effective gastric mucosal defense mechanisms. So this is good because it helps prevent the erosion of the mucosal lining and the gastric mucus, and that also will help prevent ulcers. And interestingly, a lot of the ones that contain either the calcium or the aluminum can be very constipating. So if you have a patient who already has constipation issues, you want to make sure that you choose an antacid that has mag in it. Okay, so magnesium will help with that. So they stimulate the secretion of mucus, bicarb, and prostaglandins. So all of this is great at protecting the lining of the stomach and decreasing the acidity to help you feel better again. So it will reduce the pain with its acid-related disorders. It decreases or raises the pH 1 point from like a 1.3 to 2.3, and that neutralizes 90% of the gastric acid when it does that. Right? So remember then, there's going to be a problem digesting proteins because the pepsinogen is dependent upon the hydrochloric acid to convert it to pepsin to digest protein, and it increases the resistance of the stomach lining to irritation, which is great, and it also can help increase the tone of the cardiac sphincter, which will reduce heartburn. So that's great. But when it comes to protein breakdown, not so great. So you guys should be familiar already with how different antacids are supplied. And as I said, the magnesium is the only one that doesn't really cause constipation. These can be used in our renal patients versus some of our other ones cannot. And then our combination products like our Maalox, Mylanta, those have aluminum and magnesium, the Gaviscon. If you use magnesium alone, it can cause diarrhea, and it can be dangerous when used with somebody who's in kidney failure because the kidneys can't clear it. So just be careful with that one. And again, usually we want them to be a combination product when we're talking about the magnesium. Calcium carbonate is the most common one. That would be like your Tums. It can cause constipation. And in theory, in high doses, it could increase the risk of kidney stones, although many nephrologists will tell you that your diet does not contribute to kidney stones. Renal disease, again, there's a problem clearing the calcium. And then they talk about long-term use actually can cause a rebound effect, and the person starts hypersecreting acid. Okay, so things like Tums can also be taken just as a daily supplement because they, taste good to a lot of people and they're easy to chew and swallow. You don't have to swallow a big pill, so a lot of people take those as actually just as a calcium supplement. So one of the concerns about a lot of these antacids is that an overdose or an excessive use does have the potential to cause metabolic alkalosis. So that would be a concern. And if the person were to take too many antacids, alkalosis would look like, it's on the top of 819 in your book. In box 50-1, irritability, muscle twitching, numbness and tingling, cyanosis, slow and shallow respirations, headache, thirst, and nausea. And it's, basically the manifestations of metabolic alkalosis secondary to oral antacid use. So you have a patient who has chronic renal failure and wants to self-treat with an antacid for occasional heartburn. Which medication is the best choice for this patient? Magnesium, calcium, aluminum, or the patient should not take antacids for this problem? What do you think? And then the antiflagellants are drugs that cause, like simethicone, that help break up gas. There's a lot of debate as to whether or not these are actually effective drugs, but they bind or alter the tension of the bubbles within the GI tract and kind of break them up, and they can be taken alone or in combination with antacids. So that's like Gas-X, things like that. Okay. So adverse effects are minimal, depend on the compound used. Constipation, as we said, with aluminum and calcium. Diarrhea with magnesium if taken alone. And then calcium carbonate can produce gas and belching, so oftentimes that's going to be the one combined with the simethicone. There are some drug interactions. You can look at those. They're also on the top of 819. Chelation means that they bind to them and produce basically like a chalk. And then there's adsorption, which reduces the body's ability to absorb something. So basically it binds to it like activated charcoal does. It binds to it and decreases the body's ability to absorb it. When you change the stomach pH, it increases the absorption of basic drugs and decreases the absorption of acidic drugs, so it may change the way or the amount of drug that a person is getting with their chronic medications. And then it also changes the urinary pH, and that can change excretion, so that can cause, buildup or inadequate levels of certain drugs in the body. So always make sure you're checking those levels as you go. So our H2 blockers or H2 receptor antagonists are used basically to decrease acid secretion. They competitively block the H2 receptor of acid-producing parietal cells. And the effect then is reduced hydrogen ion secretion from the parietal cells, so the pH raises and you have relief of the symptoms. It's used primarily in patients with GERD, peptic ulcer disease, and erosive esophagitis. And then there's some other things you can use it for, but those are the big ones. The only contraindication really is a known allergy, and if the person has liver and or kidney dysfunction. When we're talking about the H2 receptor blockers, all of them may increase secretion of prolactin from the anterior pituitary gland, so they all have the potential to cause gynecomastia or enlarged breasts in men when used in higher doses over long-term time frames. So cimetidine or Tagamet was the original one. This was kind of like the first drug, and then there was quite a few side effects with it, so they went back in and kind of restructured it, and now these are the newer drugs, the Axid, the Pepcid, and the Zantac, which seem to be better tolerated, and people find them to have fewer side effects, and they're a lot safer. So I went over this and this and this. All right, so just so you know that smoking decreases the effectiveness of the H2 blockers. and they should be taken 1 to 2 hours apart from antacids. So you're working with an elderly patient who's been admitted for possible GI bleed. The nurse identifies which drug is having the potential to cause confusion and disorientation. Antacids, proton pump inhibitors, H2 antagonists, or mucosal protectants. What do you think? I'm not answering them. I'm just letting you look them up so that you can learn. Okay, proton pump inhibitors. These are the newest drugs used for the treatment of acid-related disorders. They bind directly to the bottom, remember, of the little, excuse me, of the parietal cell, and that's called the hydrogen potassium ATPase pump. And it irreversibly inhibits the action of the enzyme, so it results in a total blockage of hydrogen ion secretion from the parietal cells, which is kind of cool. And the reason that it's called the proton pump is because positively charged hydrogen ions are positively charged, so they're considered protons. And so, yeah, that's why it's called a proton pump. PPIs stop more than 90% of acid secretion for 24 hours, which makes most patients temporarily achlorhydric, right? So we had talked about that in class today. That means that they don't produce any acid, so that's a concern when we're talking about things like our calcium and even potentially our protein bases. PPIs are currently indicated first-line therapy for erosive esophagitis, symptomatic GERD that's poorly responsive to other medical treatments like our H2 blockers, short-term treatment of active duodenal ulcers and active benign gastric ulcers, and then any of the hypersecretory conditions. So you'll notice they're talking about this Zollinger-Ellison syndrome, and those are people who oversecrete gastric acid, NSAID-induced ulcers, and then stress ulcer prophylaxis. And then, there's also long-term therapeutic uses like healing of erosive esophagitis, and then the pathological stuff as well. Okay, and then using to treat H. pylori. So there's different drugs on the market: Prevacid, Prilosec, Acefex, Protonix, and Nexium. They all are fairly similar in terms of how they work and how long they take to work. Some people have better relief on one versus another, and that seems to be almost like genetic as to which one works for them, and that's okay. Okay, over that and that. Sorry, talking before the slides here. So some adverse effects. It might predispose some people to C. diff infections, which is not good. We talked about the malabsorption of calcium and the increased risk of osteoporosis, and specifically wrist, hip, and spine fractures. Also pneumonia, which is interesting. So people with PPIs are at increased risk of pneumonia. And then because of the fact that calcium and magnesium and potassium are so closely related and dependent on each other in the body, it seems that magnesium also is dependent on the acidity in the stomach for absorption and does not do well when calcium is not absorbed. So I can't click back here, but let's see. The only contraindication to PPIs is a drug allergy. And just I want you to have in your mind that PPIs speed up mineral loss or demineralization. So some miscellaneous drugs, other things that we use: sucralfate, which is a sugar, is also called Carafate. You may have heard of making a slurry out of it and making Carafate slurry. Basically, it is a sucrose kind of structure that once you eat it or drink it and it comes in contact with the hydrochloric acid in the stomach, it changes chemical composition and basically becomes aluminum hydroxide and sulfate. And so it binds to the bases of the ulcers, the sulfated molecules do. They bind to the base of the ulcers and help coat and heal the ulcers, protect it. And they talk about it being almost like a liquid bandage. So it goes in and it finds essentially like the granulation tissue or the ulcerated tissue, and it adheres to it. And then the other part of that, the aluminum part of that, acts as like an aluminum salt in the GI tract to decrease reflux and heartburn. Okay, so it promotes gastric ulcer healing as well as decreasing the pH of the stomach. So we use Carafate for stress ulcers, esophageal erosions, and peptic ulcer disease. Cytotec, which is misoprostol, we use very, very sparingly in the GI world anymore because it was found to have abortifacient properties, so it was causing miscarriages and heavy vaginal bleeding, not hemorrhaging, but cramping and heavy periods. So it is wonderful as far as decreasing the ulceration of patients who are taking NSAIDs, but unfortunately it had those other side effects as well. It is pregnancy category X, which means it's absolutely not allowed in pregnancy, except when you're using it to induce labor at a full-term pregnancy. And then simethicone or Mylicon, which is also like Gas-X, is used to decrease flatulence and release gas. It says via the mouth or the rectum. I'm glad that the book explained that as well. So it works by altering the elasticity of the mucus-coated gas bubbles. Like I said, they break into these smaller bubbles and then they bubble up and they get released. Okay, so you have a patient who is getting simethicone, and it's often combined with calcium carbonate and acids because simethicone does what? Do you remember? We just covered it. So some nursing implications. So you're about to give an antacid, right? And just remember that heartburn or discomfort oftentimes is the chief complaint in a cardiac patient. So if somebody rings their bell and they say to you like, hey, I have like heartburn, you definitely want to investigate it more before you just start throwing the Tums at them. Are they pale? Are they cool? Are they clammy? Do they look like there might be something else going on that needs to be investigated, and if not, then go ahead and treat it. But if your nursing instincts are telling you that this patient may be cardiac, you want to work that up before you go down the GI route, okay? And if you suspect that they have heart failure or if they have hypertension, then watch out for the sodium content, right? Because where salt goes, water follows, and you're going to spike their blood pressure, right? Assess for allergies, pre-existing conditions, so fluid imbalances, renal disease, GI obstruction, heart failure, and pregnancy. Use with caution with other medication because there's a lot of drug interactions, and especially with the antacids. Most medications should be administered 1 to 2 hours after an antacid because it changes the pH so much in the stomach. It really alters the way that the body's able to absorb medication. Antacids may cause premature dissolving of enteric-coated medications, right? So enteric-coated medications, think about this for a second. They have a protective lining on them that don't dissolve in an acid, right? So not in the acid because the stomach is acidic. So the coating is designed to break down in a basic environment. So you give somebody an enteric-coated medication right after taking an antacid, the pH in the stomach is more basic than it normally is, and that enteric-coated aspirin starts actually breaking down, and then what's going to happen, you're going to have that aspirin free in the stomach, and the person's going to have severe GI irritation from the aspirin in the stomach. Does that make sense? Hopefully, you can put those little pieces together. So you want that 1 to 2 hour window around those antacids. Chewable tablets should be chewed thoroughly. Liquids should be shaken well. And then always we make sure that we give 8 ounces of water, except the rapid dissolve forms. Long-term self-medication with antacids can be dangerous, like we talked about today. So they can mask underlying diseases, malignancy and bleeding ulcers specifically. So you want to make sure that you're doing good patient education, and always, encouraging the patient to talk to their doctor about everything that they're taking. Monitor for things like nausea, vomiting, belly pain, diarrhea, constipation, and that hyperacidity, that rebound hyperacidity with calcium-containing products. And then notify the healthcare provider if symptoms are not relieved, and that's really important. And I mentioned this in class, but lansoprazole can be opened and the granules sprinkled over a tablespoon of applesauce and then swallowed immediately. But omeprazole has to be taken whole and cannot be crushed, opened, or chewed. Okay, and then what's interesting is omeprazole can actually be given with antacids and doesn't have to be separated out. So in your book on 826, it talks about some of the different administration things. Pantoprazole can be given orally without crushing or splitting the tablet. And then, if you're giving it IV, make sure that you're giving it diluted and over the correct time frame. All right, so with the H2 blockers, 1 to 2 hours before or even after antacids. Be careful with these on the IV doses. You need to make sure you have the right dose and the right time frame so that you don't cause any problems with blood pressure. And then with the PPIs, we worry about liver disease, right? And then there's some drug interactions. So diazepam, which is Valium, phenytoin, which is Dilantin, and then it can change the INR, so we worry about bleeding on patients who are on warfarin or Coumadin. And as I mentioned, pantoprazole can be opened and you can sprinkle out the granules. Okay, we got to worry though about clogging if you're using it through an NG tube, but you can mix it with applesauce and then just give it to them immediately. And then they talk about apple juice. Do not chew or crush delayed release granules. That would be important. When providing education regarding the use of proton pump inhibitors, which statement will the nurse include? Take the medication along with the first meal of the day. Take the medication on an empty stomach 30 to 60 minutes before eating. Take the medication when you have symptoms of heartburn, or take the medication at bedtime with a snack. So what do you think? The dosing instructions for PPIs are on 823. All right, that's it. Enjoy.